Okay, here we are with chapter 42, Obstetrics. This is a pretty lengthy chapter that contains a whole lot of information related to this category. So this particular chapter is broken down into 5 different parts. And with that, let's go ahead and get started on part 1. So it's important to realize, or important to make the distinction, that pregnancy is not a disease. It is a perfectly natural process that doesn't always require a whole lot of medical treatment on our part as the medics. However, pregnancy and childbirth are some of those times when a mother and her unborn child face some of the more increased health risks that they might face. Several societal factors may come into play as well. Then these factors may put either the mother or the baby or both of them at a greater risk of health complications. Of these, the mother's education level plays a small role in that. Of course, access to quality personal and prenatal health care, and how much support that they have from family and loved ones. All of these kind of play a role in the overall health of the mom and baby. A calm, confident, reassuring approach from the healthcare provider can greatly reduce the patient's anxiety. And of course, thanks to modern medicine, maternal and infant mortality rates have dropped significantly over the years. All right, so let's get into a bit of a review. This shouldn't be new information for you guys, but a worthwhile review, I think, is going to be helpful. Female reproductive system, of course, includes several key organs or organ systems that are important that we kind of touch on because they're all going to play a role in the whole pregnancy process. Women have 2 ovaries, which produce eggs and hormones, and then 2 fallopian tubes that actually connect the ovaries to the uterus. The uterus is also known as the womb. This is where that fertilized egg will implant and where the baby will grow during the entire pregnancy process. The cervix is the lower part of the uterus that opens into the birth canal. And in this, the vagina is also known as what we'll typically refer to as the birth canal, and it connects the uterus to the outside body. And then we have the mammary glands, which are located in the breasts, and these produce milk for breastfeeding. And there's various parts of the external genitalia that includes all of those structures that are visible on the outside of the body. The ovaries are a pair of small glands located on either side of the uterus. They're similar in function in some ways to the testes in males. Each ovary contains around 200,000 follicles, and each follicle holds an immature egg. Women are born with all the eggs that they will have in their lifetime, and that's roughly about 400,000 of them in total. During each menstrual cycle, several follicles will begin to mature, although typically only one follicle will mature completely enough in order to release an egg. The remaining follicles will break down and be reabsorbed by the body. The cycle begins when the anterior pituitary gland releases something known as a follicle stimulating hormone. This triggers the maturation of an egg or an oocyte. As the cycle progresses into the pre-ovulatory phase, the anterior pituitary also releases a luteinizing hormone, which stimulates ovulation. This is the release of that mature egg. The luteinizing hormone produced throughout the cycle and signals the ovarian cells to produce other important hormones such as estrogen, progesterone, and inhibin. After the egg is released, the remaining part of the follicle becomes the corpus luteum, which continues to produce some hormones for a short period of time. And then at the end of pregnancy, the hormones prostaglandins and oxytocin trigger the uterine contractions and the onset of labor. So all this plays an important role. All of these hormones, remember we talked about this in previous chapters, how these hormones cause remote cells to do certain things, and that's very much true with what's going on in the ovaries. After ovulation, the ovum travels from the ovary to the uterus through the fallopian tube. And there's these tiny like hair structures called cilia, similar to the cilia in the lung, in the respiratory passages, that sweep this egg along the fallopian tube. And then we have some smooth muscle contractions on the inner lining of that tube, along with the cilia, that kind of help to kind of push that egg towards the uterus. So it's kind of a moving, it's a bit of a process to get that egg to kind of move in the right direction. If the egg meets up with sperm along the way, fertilization may occur. Fertilization typically happens within 24 hours after ovulation. If the egg isn't fertilized, it dies and is reabsorbed by the body in about 36 to 48 hours. If fertilization does occur, the lining of the uterus, the endometrium, will begin to thicken, and its glands will begin to secrete nutrients to help support the implantation of this fertilized egg and spur the early growth of an embryo. The uterus is a pear-like shaped organ located between the bladder and the rectum. It plays several key roles in reproduction. Of course, it's where the fertilized egg implants. It's also where the fetus grows and develops during the entire pregnancy. It's also a site where labor and delivery occurs, because it's responsible for a lot, you know, those labor contractions and all that pushes the baby out. There's 3 layers of tissue to the uterus. We have the perimetrium. This is the outer protective layer that's kind of between the organs, the other internal organs, and the uterus. And then we have the myometrium. This is the thick middle layer that's made up of smooth muscle. And the endometrium, which is the inner lining. This is the part that thickens each month in an attempt to try to support a potential pregnancy. At the base of that, we have the cervix, which is a the narrowest part of that. Excuse me. And this opens up into the birth canal, or the vaginal opening. Of course, the vagina is a muscular tube like organ that's lined with mucous membranes. Its primary functions are, of course, it plays a major role in sexual intercourse, and then it provides passage for menstrual flow, for the menstrual flow to exit the body, and it acts as the birth canal during childbirth. Of course, the vagina has an amazing ability to stretch in order to accommodate the delivery of a fetus. But this doesn't always happen in the time frame that delivery is happening. Sometimes delivery moves a little faster and things aren't able to stretch at quite the rate that they need to. If this doesn't happen, the tissues in and around the perineum may tear, and this can lead to significant pain as well as bleeding. In a hospital setting, a physician will oftentimes perform an episiotomy, or essentially a procedure that they'll make a cut, and this will help to prevent tearing. However, in the pre-hospital setting, the treatment is limited to essentially providing some gentle pressure against the newborn's head to keep the head from having too explosive of a delivery, and allowing a little extra time for some of those tissues to expand and kind of catch up. Mammary glands are specialized sweat glands, primarily made up of adipose tissue. Their main function is lactation, providing nourishment for the newborn. Some signs that a woman is likely pregnant might include breast enlargement, tenderness, and even milk excretion from the breast. All right, so let's move on to conception and fetal development. We'll talk about how this whole process works. So once the egg is fertilized and implanted, both the egg and the mom undergo significant changes. The egg starts absorbing uterine fluid through its cell membrane. Cell division speeds up rapidly, and the cells multiply on the outer surface of the egg and begin to form these layers that will ultimately develop into the fetal membrane, the placenta, and the embryo itself. So all these layers are going to start to develop, and all this happens relatively quickly. The egg, now called a blastocyte, migrates to the endometrial wall and becomes implanted about a week after conception. Then we have a lot of enzymatic activities that dissolves some of the endometrial tissue to provide nourishment for the developing embryo. The implantation process may cause light, painless vaginal bleeding because of this connection where it's trying to bond with the side of the endometrium. This implantation triggers the development of placental tissue. This formation stimulates the release of human chorionic gonadotropin, signaling the start of pregnancy. The corpus luteum begins producing hormones to support the pregnancy until the placenta is fully developed. 2 weeks after conception, the blastocyte transforms into an embryonic disc. The placenta then begins to connect to the outer layer of the blastocyte, where the spaces fill with maternal blood from the mom. This connection allows the embryo to draw nutrients from maternal circulation, and this also marks the beginning of the umbilical cord, so that's when that starts to form. 3 weeks after conception, the egg has now developed into an embryo. Organogenesis begins with the development of key body systems such as the central nervous system, cardiovascular system, the spine, and portions of the skeletal system. An S-shaped tubular heart actually begins to beat, and blood cells begin to start circulating through the circulatory system. The 4th week of pregnancy, the placenta develops and begins performing some critical functions. It acts as an early liver for the fetus, or for the growing embryo. It synthesizes glycogen and cholesterol, metabolizes fatty acids, begins to produce antibodies that will help protect the fetus. It provides that respiratory gas exchange that the fetal lungs can't do yet, transports nutrients from the mother's circulation to the growing fetus, and it excretes waste into the maternal circulation or into the amniotic fluid. It also transfers heat from mom to fetus and produces that chorionic gonadotropin hormone, which helps maintain the pregnancy, stimulates changes in the mom's breasts, the cervix, and all those places in preparation for delivery and motherhood as that time begins to get close. It also forms a barrier against some harmful substances to kind of protect the fetus, from things that may be in the mother's bloodstream. The umbilical cord connects the fetus and the placenta through the navel of the fetus. Fetal circulation differs from normal circulation. This is where the umbilical vein carries oxygenated blood from the placenta to the fetus, and the umbilical arteries carry deoxygenated blood from the fetus to the placenta. This circulation actually bypasses the lungs until birth, and when the baby takes its first breath, that's when all that switches back over to the baby's circulation. We'll talk about that a little bit later. The amniotic sac surrounds the fetus, and it's filled with amniotic fluid. This provides the fetus with what essentially amounts to a weightless environment. Later in pregnancy, the fetus will swallow amniotic fluid, and it will also pass waste back into the amniotic fluid. The 4th through the 8 weeks of embryonic development are the most crucial. During this time, major organs and body systems are most vulnerable to damage as they form. Some prescription and over-the-counter medications may harm the fetus during this developmental stage, and the use of illicit drugs, tobacco, alcohol, and other toxic substances are going to increase the risk of congenital disabilities developing in the future. The gestational period the gestational period is the time it takes for the fetus to develop in the uterus. This normally lasts about 38 weeks, but it is calculated from the first day of the last menstrual period. Because the hormonal signals are sent to the corpus luteum 2 weeks after conception, those 2 weeks are actually added into the calculation, and the result is a total of 40 weeks of pregnancy, but the actual growth is closer to 38 weeks. All right, so let's talk about some maternal changes that happens during pregnancy. There's a lot of changes that occur during pregnancy, and what these things can do, these things are going to have a big impact on the mother that's carrying the child. They're going to alter their normal response to trauma, and they may actually even exacerbate other existing medical conditions or even create new ones that can become problematic. The most significant changes during pregnancy occur in the uterus. Before pregnancy, the uterus is about 3 inches long and 2 inches wide and maybe about an inch thick. It only weighs about 70 grams or roughly 2.5 ounces. And it only has a fluid capacity of about 10 milliliters, so not really much to write home about. At the end of pregnancy, however, the uterus may weigh as much as 11 or 1,200 grams or 2.5 pounds. And it will have the capacity to hold roughly about 500 milliliters of fluid. So it grows and stretches dramatically during that time frame. One of the ways that's helpful in knowing this, it can actually help us identify developmental problems. We can do a measurement of the fundus to help to identify those. We measure the fundus in centimeters vertically from the top of the pubic bone to the top of the fundus. The length is roughly going to correspond with the length of gestation. For example, if the patient's 32 weeks pregnant, the measurement should be around 32 centimeters. If the measurement is different than expected, it could indicate there's maybe some uterine growth problems or even a breech position if it's shorter, or the possibility that there's more than one baby in there if it's longer. The enlarged uterus puts pressure on the lower intestines and the rectum. This often leads to constipation. Also, the increased progesterone levels can cause the smooth muscles in the GI tract to relax, and this can result in heartburn or excessive burping. The stomach doesn't empty as quickly either, and this increases the risk of vomiting during an emergency. Changes also occur in the urinary system. The kidneys will actually increase in size and volume. The ureters will widen, and this is going to lead to increased urinary frequency, which also creates a higher chance of urinary tract infections if the bladder isn't emptied frequently. And then we have a lot of hormones that are going to cause some changes in the skin, hair, eyes, in various parts of the body. These hormones are going to cause those changes, and most of those changes will be permanent changes. Pregnancy significantly impacts the woman's circulatory system. The blood volume is going to increase by 30 to 50% depending on the patient's size, whether it's a single or multiple gestation, or the number of pregnancies and deliveries that they've had. That gravity parity will kind of determine how much of that blood volume is going to increase. The increase in blood volume is necessary to meet the metabolic needs of the developing fetus, to adequately perfuse maternal organs, and to help compensate for the blood loss that normally occurs during delivery. Number of red blood cells is going to increase, of course. This increases the woman's need for the mother's need for iron. The fetus will deplete the mother's iron stores, which can lead to anemia if she doesn't take prenatal vitamins and keep those iron levels up. White blood cell count also increases. The levels of clotting factors and fibrogen concentrations rise. The size of the heart is going to increase with the blood volume by an average of about 10 to 15%. Cardiac output will increase by 30 to 50% more than before pregnancy. It'll reach its maximum capacity by about 22 weeks gestation, and then it'll decline about 20% as the baby nears the term. As the uterus enlarges and the diaphragm elevates, those internal organs are going to make a shift. They're going to make room. This causes the apex of the heart to shift a little bit upward and forward, and even a little bit to the left. So the systolic and diastolic murmurs become a little bit more common. Because of this shift, we'll see some EKG changes, which are not uncommon. The heart rate will gradually increase during pregnancy by about 15 or 20 beats per minute up to the term of the pregnancy. EKG changes may include ectopic beats, SVT, which is considered normal in pregnancy, slight left axis deviation because of the way the heart shifts a little bit, and some lead 3 changes where we might see some low voltage QRS complexes, T-wave inversions or flattening, along with the occasional Q wave. Sensitivity to body position increases as the gestation process progresses. Lying supine can cause compression of the inferior vena cava and reduce venous blood return to the heart. This can also occur due to pressure from the fetus on the common iliac vein. If that pressure is not relieved, cardiac output is going to decrease. Systolic pressure may decrease until around weeks 24 of gestation. Blood pressure may begin to rise from week 24 up until birth. And venous pressure progressively increases in the lower extremities in late pregnancy. This often contributes to a slow venous return, maybe even some pooling and dependent edema. Varicose veins are very common in this stage of the pregnancy as well. Bedridden women, or those who lie down frequently, are at a greater risk of developing deep vein thrombosis, which can lead to a pulmonary embolism. The birthing position during labor can add an additional amount of stress to the cardiovascular system. The lithotomy position, that is the standard position used in the United States, with legs or feet up in the stirrups and all that, this increases the heart's workload significantly during labor. So with an already stressed and overworked heart just from gestation in a normal labor, when we place them in this position, it adds additional stress to it. So if the mom already has heart disease or other cardiac issues, this can lead to ventricular failure, pulmonary edema, or even heart failure. It's important to realize too that with these patients that already have some issues there, the pain and pressure during labor can actually lead to full-on cardiac arrest. The respiratory system in the mom also undergoes a lot of stress during pregnancy. As that diaphragm is pushed upward into the thoracic cavity, it causes about a 1.5 inch displacement. So it's pushing everything up. The rib margins begin to flare outward in compensation and increasing the lower thoracic diameter and the total thoracic circumference by as much as 2.5 inches. Maternal oxygen demand increases. Progesterone decreases the medullary respiratory center's threshold to carbon dioxide. This also causes, this progesterone also causes the bronchi to dilate, and it begins to regulate some of that mucus production. An overall decrease in airway resistance begins to occur, so making it easier for mom to get air in. Oxygen consumption increases by about 20 to 40%. Tidal volume gradually decreases by about 30 to 40%, leading to an increase in minute volume by as much as 50%. So as the tidal volume decreases, the minute volume increases to compensate for the changes in the amount of air that can be brought in. A drop in PCO2 of about 5 millimeters is not uncommon either. And then the minute ventilation is going to rise by about 10 liters per minute. So it's going to try to compensate for that decrease in space. At term, diaphragm displacement causes a decrease in respiratory reserve volume, functional residual capacity, and residual volume as well. So that diaphragm displacement takes away the mom's ability to react or respond to certain things. It's also going to cause an increase in tidal volume and an increase in inspiratory reserve volume. Structural changes in the respiratory mucosa result in an increased vascularity and an increased likelihood of edema. Maternal metabolism also undergoes some massive changes. The most obvious change is weight gain and physical structure altercations. Weight gain is roughly an average of about 27 pounds. This is in part by the increased blood volume and intracellular and extracellular fluid, which makes up about 6 to 7 pounds. Uterine growth accounts for about 3 pounds of that. Placental growth is a couple of pounds. The baby itself is roughly 7 pounds. An increase of breast tissue of 2 to 3 pounds and an increase in proteins and fat deposits throughout the body kind of rounds out the rest of that. So the hormone relaxin actually begins to soften some of those collagenous tissues and relaxes the ligament system, the ligamentous system. The resulting pubic laxity, for lack of a better term, helps kind of facilitate delivery through the pelvic ring during labor. So this hormone tries to get everything to begin to relax and soften to where that it makes labor more possible, making that baby pass through the birth canal. The demand for carbohydrates increases, and several hormones help to compensate for the increased carbohydrate needs. Women that are predisposed to diabetic state may become chemically diabetic during pregnancy, but typically that returns to normal in the postpartum days, after the baby's delivered. During pregnancy, what happens is the pancreas is going to secrete greater amounts of insulin at a faster pace, and the cells may actually become more sensitive, or the cellular sensitivity to insulin may actually decline during this time as well. Estrogen blunts the action of insulin, while progesterone decreases the insulin utilization. This process is balanced in healthy women, but it's much harder to maintain for women who are either obese or they're predisposed to gestational diabetes or they're currently diagnosed with diabetes. This process starts to become less clear, and it's a little bit tougher to begin to manage. All right, some cultural considerations that we need to make when it comes to dealing with pregnant women. Realize that we're a melting pot of lots of different cultures out there, and we need to take several things into consideration when we're dealing with cultural values. Some cultures absolutely may not permit a male healthcare provider to assess or examine a pregnant patient. This is not uncommon, and there's several cultures that this might come into play with, so just be aware of that and be prepared for that. Different cultures may view pregnancy differently, so for some it may be no big deal, for others it may be a very big deal, and there may be everything in between that. So responsibility is limited. Our responsibility as providers is limited to providing care and transport. When in doubt with this, when there's restrictions or when there's cultural issues at play here, we need to respect those, provide care and transport. The United States has a very high teenage pregnancy rate compared with other developing countries. Whether or not that's because the United States does a better job of reporting those, or whether that's an actual statistic difference is, tough to say, but we do have a very high rate of teen pregnancy. Pregnant teenagers at times don't know they're pregnant or may be in 100% denial that they are. Remember that pregnancy is possible whenever you're assessing a female patient, a female teenager. Of course, respect their privacy and their independence. If possible, the patient should be given privacy away from parents and bystanders during the medical history and exam. These are going to create unique challenges when you come across these, and especially in those instances where delivery is imminent. It's going to be a tough situation to be in, and you're going to have to navigate those waters carefully. Okay, so how do we assess the pregnant patient? Well, some things we want to start off with. We kind of want to know where we're at. What are we up against here? So some terminology that is helpful to understand. Now, your patient's probably not going to use this terminology, and if they do, they probably know as much or more about childbirth than you do. So gravity is the number of times a woman has been pregnant, regardless of the outcome. It's purely how many times they've been pregnant. Parity, on the other hand, is the delivery of an infant who is alive. So they have a living birth. So gravity is the number of times they've been pregnant. Parity is the number of live births. And then we can break that down a little bit further. We have prima gravida is a woman who is pregnant for the first time. Remember, that's gravity. Prime is first. Prima gravida is a woman that's pregnant for the first time. Prima para is a woman who has had only one live birth, live delivery. Stillborns don't count as a live delivery. Multigravida is a woman who has had 2 or more pregnancies, regardless of outcome. So they could be prima para multigravida, meaning they've been pregnant multiple times but have only had one live birth. So you kind of see how this plays out. It can get a bit confusing. So multipara is a woman who has had 2 or more deliveries. Grand multipara is a woman who has had 5 or more deliveries. And then nullipara is a woman who has never delivered. Now, this terminology is probably not terminology you're going to use much in your documentation. You're welcome to use this, or you can use very simple terms. It's important for you to understand this terminology in those times when you're transporting a patient from facility A to facility B, and this terminology is in their chart, and maybe it conflicts with the story that you were given at the sending facility or something along those lines. So it's important to understand there is some unique terminology when it comes to pregnancies and childbirths. So anyway, scene size up, of course. With every scene size up, we're going to take standard precautions. And with this, we're probably going to go up a level if there is the likelihood of imminent delivery. Gloves, masks, eye protection, gown, all of that stuff. We should use all of those things in these field deliveries anytime there's the potential for fluids being sloshed and splashed and those kinds of things, which childbirth would be those instances. Consider calling for specialized resources when and where applicable. Determine the mechanism of injury or nature of illness. If it's not pregnancy related, we need to make sure that what we're dealing with and how that's going to impact our pregnant patient. Altered a balance from weight and size of the fetus and relaxed musculature from hormones may cause falls and spinal injuries and those kinds of things much easier. Realize that the further along the mother is, the more her center of gravity is impacted by the pregnancy. And if it's a multi-gestational pregnancy, meaning she's carrying multiple babies, she may be even larger, and that's really going to impact her center of gravity, and the likelihood of her getting off balance and falling becomes much, much higher. So those are always concerns that we need to be aware of. Of course, get that general impression, and And if it is obstetric related, if it's delivery related, we need to make a determination if that delivery is going to be in the next few minutes or if there is time, if we've got time. If we've got time to evaluate things further, or if we need to, be ready to catch a baby. Evaluate trauma and other medical problems first, and then assess the impact of those things on the fetus. Use the AVPU scale to determine level of consciousness, just like we do with any other patient. It's pretty standard. Of course, if there are any life-threatening airway conditions, we want to make sure that it's usually not an issue with an uncomplicated birth. So manage those in trauma and medical conditions. However, we want to make sure we assess the airway and breathing adequacy, and if necessary, provide some airway management and high flow oxygen. Quickly assess for life-threatening bleeding. Significant bleeding after delivery is not normal. It's normal to have a little bit of bleeding, but if that bleeding continues, it is abnormal, and we're going to have to address that. Assess skin color, temperature, and condition, and check for a pulse. Establish a minimum of 1 IV in preparation for a delivery of a fluid bolus if needed. Ideally, it's going to be a little larger bore IV if possible. If you're thinking delivery is going to be imminent, a larger bore IV and maybe even 2 IVs wouldn't be out of the question. If delivery is imminent, you're just going to have to prepare for delivery there at the scene. If not, transport and perform the rest of your assessment en route to the hospital. If you've got time, get moving to the hospital. If not, you're going to have to deliver there at the scene. Administer oxygen. Transport the mom lying on the left lateral recumbent position when possible. If you have to use spinal motion restriction, secure the mom to a spine board and elevate the right side of the board to prevent the spine supine hypotension syndrome. We want to make sure that we can get good return air or blood flow to the heart. We want to make sure that we're not reducing cardiac output. Of course, then we're going to provide rapid transport for patients with significant bleeding, who are hypertensive, who have seizures, and who have an altered mental status. These are the same patients we're going to, if they were not a pregnant mom, these are still going to be rapid transport decisions. So nothing really changes unless there's an imminent delivery. And then we're really going to be thinking hard if we have any of these things going on. And if there is anything that's going to slow that delivery from happening immediately or within the next couple, 3 or few minutes, if there's anything that's going to prevent that from happening, then we need to be going, especially if our patients are exhibiting any signs of these things, because we've got a problem going on. Okay, so that's part 1. We will be back in a bit with part 2, and we'll continue our discussion on obstetrics.